Hello everyone, you're watching sqadia.com and today our lecture topic is endocrine bone disorders. As you know that bone is actually involved in calcium metabolism in our body. It is the largest reservoir of the calcium. So what if it actually loses calcium or it actually increases in calcium? This disturbs the calcium metabolism in our body as well. And once calcium metabolism is disturbed, this actually indirectly affects the phosphate as well as magnesium. So there is actually this hypercalcemia, hypocalcemia, hyper and hypophosphatemia, and hyper and hypomagnesemia are kind of interlinked. And how does all this interlinkage comes in? Because the calcium level of bone is actually regulated by two things. One is parathyroid hormone and the second is vitamin D. And we'll be going through what happens if there is hypocalcemia. We'll be going through the causes of hypocalcemia, clinical features, how to investigate and how to treat this condition. Hypocalcemia is actually it's the most important hormone in our body for bone metabolism is actually parathyroid hormone. It is released by the parathyroid glands. It acts on the bone and results in actually release of calcium from the bone into the serum. If for any reason the calcium is not either absorbed from the gut or it actually increasingly secreted by the kidney, this would result in serum calcium levels to be decreased. Once this happens, this is sensed by hyperparathyroid by the parathyroid hormones, and there is released parathyroid hormone, leading to increased calcium level. Although the restoration of calcium has been restored in the serum, but at what cost? That is at the cost of bone. So actually, yes, calcium metabolism and calcium levels are being maintained, but at the cost of bone. So this actually weakens the bones as well. So the most important regulator of calcium on bone is actually parathyroid hormone. Symptomatic hypocalcemia is also rare, but if it does occur acutely, it's an acute emergency. Common causes are hypoparathyroidism, vitamin D deficiency, and chronic kidney disease. What does vitamin D deficiency do? There is just not enough vitamin D to absorb calcium from the gut. So eventually there will be low calcium levels in the serum as well as in the bone. This would result in low hypocalcemia or low calcium levels. If there is not just enough functioning parathyroid gland, this will not be able to secrete parathyroid hormone. This will then parathyroid hormone will not be present in sufficient quantity, or there is some kind of a problem with the receptors of the parathyroid hormone that would result in the hypoparathyroidism, eventually leading to hypocalcemia. Although the calcium would be present in the body within the bones, but it will not be released into serum level, calcium. Calcium is not actually released into the serum so that the calcium metabolism can be balanced. Some of the causes of hypocalcemia include vitamin D deficiency. This could be acquired, that is a dietary deficiency, or malabsorption syndrome such as Crohn's disease, sprue. These are all malabsorption syndromes. As a result, enough calcium is actually not absorbed from the gut. So it could be enzymatic deficiency such as 1-alpha hydroxylase mutation. This is an enzyme which converts the hydroxycholecalciferol or dihydroxycholecalciferol into calcitriol, or the activated form of vitamin D in kidneys. If it is absent or it is for any reason there is a mutation in the gene that the enzyme is defective, that vitamin D cannot be converted from one form to an activated form. This will eventually result that it's kind of creating vitamin D deficiency, that there is not enough activated vitamin D present so that it can cause absorption of calcium and phosphate from the gut. The other is chronic renal failure. In case of chronic renal failure, this is actually deficiency of 1-alpha hydroxylase. Similarly, absorption of calcium is also affected, so there is excessive loss of calcium. Hypoparathyroidism, as I just told you, because there is not enough PTH, this will not release the calcium from the bone to the serum. Then certain congenital syndromes such as Digeorge syndrome, calcium sensing receptor mutation, and pseudo-hypoparathyroidism, we'll be discussing that in details. Then there are acquired conditions such as autoimmune or post-parathyroidectomy. Usually, parathyroid surgery is rarely performed, but in sometimes with thyroid surgery and hypothyroidism or hyperthyroidism, very common disease. Certainly, with thyroid surgery, parathyroid glands are also removed. This leads to a situation called as hypoparathyroidism. That is, there is not just enough parathyroid glands to produce parathyroid hormone. Once parathyroid hormone is not produced, this will produce a situation of hypoparathyroidism. Then hypomagnesemia, as calcium and magnesium metabolism are also interlinked, and low magnesium levels actually the parathyroid hormone. Magnesium is required to release parathyroid hormone from the parathyroid glands. If there is not just enough magnesium there, then not enough PTH or parathyroid hormone will be released, leading to hypomagnesemia and hypoparathyroidism, and eventually leading to hypocalcemia. Then certain conditions such as pancreatitis, hyperphosphatemia, and drug-induced these conditions, they all cause hypocalcemia. Denosumab and zoledronate are actually, zoledronate is a bisphosphonate, and denosumab actually acts on the rank receptors, that is receptor activated nuclear K factor beta ligand, which is present on osteoclast, is actually inhibited by these denosumab. Osteoclastic activity is actually inhibited, and once osteoclastic activity is inhibited, this results in decreased resorption of bone. Once the bone resorption is decreased, the calcium which is present inside of the bone cannot be released into the serum. This will eventually lead to hypocalcemia. Other causes of hypocalcemic hypoparathyroidism, as I just told you, although it's a very rare cause, but it can most commonly associated with hypoparathyroidism, that is low functioning parathyroid glands. The important cause of hypocalcemia following parathyroidectomy can be autoimmune disease occurring due to iron overload from hemochromatosis, magnesium deficiency interfering with parathyroid hormone release. Usually it's a congenital issue, and it can be associated with Digeorge syndrome and genetic disorders which are associated with active mutations of calcium sensing receptors. Now the point is, if there is not enough parathyroid hormone, eventually this will lead to calcemia. Now this could be acquired. For example, there is magnesium deficiency, and magnesium is needed for the parathyroid hormone release, or there will be iron overload for hemochromatosis, or it could be congenital, such in case of Digeorge syndrome, or there may be receptor mutations that parathyroid hormone is acting on it, but the receptor on which it has to act is actually mutated. Therefore, it cannot perform its function of actual release of calcium from the bone to the serum. Diagnosis of hypocalcemia is actually made by most common is like finding of a low serum calcium, finding of elevated serum phosphate, and low or absent PTH. Now that depends upon whether it is associated with hypoparathyroidism, then it would be low or absent. But if it is not associated with hypoparathyroidism, PTH may be normal, but still the calcium may be low. In case of activated mutation of calcium 7 receptors, PTH level may be close to normal range, but not as low as in calcium levels. Now, important point is, if PTH is released by a normally functioning parathyroid glands, but the receptor on which that PTH has to act is defective, that means despite that PTH normal, if they're normal or high, they are not able to function the way they should be functioning, and eventually it would create a kind of a situation called as pseudo hypothyroidism, hypoparathyroidism, eventually leading to low calcium levels. Now, causes of hypocalcemia leading to pseudo hypoparathyroidism. As you know, the term word pseudo means it's false. It's although it's the disease is depicting the clinical picture of hypoparathyroidism, that is, there is low or absent calcium PTH levels, low calcium levels, but it's not due to the problem of PTH hormone, that is parathyroid hormone, or it is due to parathyroid gland, but the problem is somewhere else. Rare genetic cause of hypocalcemia, peripheral sensitivity to parathyroid hormones is actually impaired. Where on peripheral tissues where the parathyroid hormone has to act on those receptors, that is where the problem lies. There is a loss of function or mutation in GS alpha subunit of G proteins. Now this leads to two types of it, type 1 and type 2. Type 1 is further subdivided into type 1A and type 1B, and type 2 there is only one type. Type 1A and type 1B and type 2. Now type 1A and B is characterized by defective urinary cyclic AMP response to parathyroid hormone. That is why in these type 1A and B, although it's a very rare disorder, but there is usually increase, there is low calcium, there is low PTH or absent PTH, and there is usually increased cyclic AMP. When in case of type 2, type 1A is associated with specific morphological features of Albright's hereditary osteodystrophy, like short stature, short fourth or fifth metacarpals, mild mental retardation. Now, this is very rare genetic disorder such as Albright's hereditary osteodystrophy. Usually, it is associated with hyperparathyroidism. That's why it is called as. Although hypoparathyroidism association, pseudo hypoparathyroidism association with Albright is termed as type 1A. Usually, the pseudo hypoparathyroidism, the phenotypic features of Albright hereditary osteodystrophy, but with a normal calcium and normal calcium metabolism. Now, this is one you need to understand, that sometimes a patient comes to you with let's suppose the patient comes to you with a short stature, fourth and fifth metacarpals are small, and you're suspecting Albright osteodystrophy. It should be associated with hypoparathyroidism. But sometimes what happens is, in case if it is associated with hypoparathyroidism, there will be low calcium, there will be low PTH, but there will be receptors would be normal. But in case if it is Albright osteodystrophy associated with pseudo hypoparathyroidism, there will be definitely low calcium, low PTH or absent PTH, and associated with defect in the receptors as well. So what are the features of clinical features of hypocalcemia? They include mild asymptomatic hypocalcemia. Severe usually includes tetany or numbness, especially the carpopedal spasm. As you can appreciate in this diagram, the patient comes to you with this carpopedal spasm. These are called as Acoucher's hand. Sometimes the gynecologist, when they're taking out the baby, they have to make this sort of a position. That is why it's called as Acoucher's hand, and there is severe carpopedal spasm. Muscle spasm, which is mostly carpopedal. There is convulsion or cardiac arrhythmias may be associated with hypocalcemia. Laryngeal spasm, patient may not be able to talk properly, or there may be a problem with the breathing as well. Atrocious sign is when you're trying to take their PP and cuff is inflated. Although there is once the PP cuff goes above the systolic pressure, as there is ischemia, and this precipitates hypocalcemia, leading to spasm of those muscles of the forearm, as the cuff has been tied over here, and once the pressure goes above the systolic, the patient's hand show a classical deformity of Acoucher's hand, or they show carpopedal spasm. Why? Because now there was already hypocalcemia, now with blockage of the arterial blood supply, as now the cuff has been inflated above the systolic level, this hypocalcemic effect has been actually enhanced, leading to spasm of these muscles. Diagnostic sign is actually irritation of the facial nerve. In the patients with usually hypocalcemia, if provocative test is actually performed, that a patient's facial nerve is irritated over here at the temporomandibular joint, although you cannot appreciate any spasms, but in case of a patient who is hypocalcemic, this would result in facial spasm of the muscle, and which would be very clearly visible. Other ECG findings include prolongation of QT interval on ECG. So how to investigate? We need to rule out the cause first, whether it is either due to low functioning parathyroid gland, that is in case of hypoparathyroidism, or is it pseudo hypoparathyroidism, or is it just because of the decreased dietary absorption from the calcium. Serum calcium would definitely tell us that it is hypocalcemia, but we need to perform other tests as well so that we can rule out is the actually cause of hypocalcemia. Conditions usually associated with chronic hypocalcemia include pseudo hypoparathyroidism, which usually give a clue as well sometimes that there is excessive soft tissue calcification. There's excessive soft tissue calcification in basal ganglia in subcutaneous tissue. We need to get a radiographs to the forearm so that if there's soft tissue calcification on the soft tissue, we would know that most likely this is hypocalcemia is due to pseudo hyperparathyroidism. Other important investigations which need to rule out is analysis of calcium sensing receptor mutations, because it may be due to that hypoparathyroidism glands are normal, parathormone is secreted normally, but it says receptors are problematic, or they are genetically mutated. Therefore, the parathormone cannot act normally and perform a normal function. Check magnesium levels. Why we need to check magnesium level? Because hypomagnesemia can delay the release of parathormone, eventually creating a situation of hypoparathyroidism. Then we need to check out the family history. Why? Because certain such as pseudo hypoparathyroidism may be associated with certain syndromes, and we need to check not only calcium but also phosphate and parathormone levels. And usually in case of hypocalcemia, there will be either low phosphate or high phosphate and low or absent PTH level. But if there is urinary cyclic AMP excretion is increased, then definitely the picture is going towards the hypercalcemia due to pseudo hypoparathyroidism. So what's the treatment of hypocalcemia? The first and foremost is actually acute hypocalcemia is a medical emergency, and we need to treat it very urgently. It's the first thing is it has to be treated with intravenous calcium. That what is actually absent is you have to give to the patient, and it is given in form of intravenous calcium gluconate. Chronic hypocalcemia is often managed by vitamin D metabolites such as cholecalcitriol. Now, what does vitamin D do? It increases the absorption of calcium from the gut. But if the cause once acute emergency is settled, we need to rule out the cause first. What is actually causing? Is it some kind of a gut pathology, such as ilex sprue, Crohn's disease, or ulcerative colitis? If that is the problem which is actually decreasing the calcium absorption, we need to sort that out. Or is it problem is with the parathyroid glands, or it's a hypoparathyroidism, or it is a pseudo hypoparathyroidism? Then the treatment is actually directed to the cause. But for that, just to avoid an acute episodes of hypocalcemia, vitamin supplementation should be given. In patients with chronic hypoparathyroidism, replacement treatment is a terapeptide, which is actually a parathormone analog. Cases of activating mutations of calcium sensing receptors, newly developed inhibitors may play a role in the future. But yes, they are actually there's no definitive trials available. As for example, randomized controlled trials of these receptors are not available. But maybe in future, once the drugs get approved by the FDA, they may have a role in preventing hypocalcemia, especially in those patients who have problem with the parathormone sensing receptors in their body. In this, we were dealing with hypocalcemia. It's an acute emergency if it presents acutely, although acute emergency can be dealt with giving intravenous calcium gluconate, but we have to rule out the cause, whether it is hypocalcemia due to dietary insufficiency or problem of the gut, such as ilex sprue, ulcerative colitis, or Crohn's disease, or is this hypocalcemia going on due to hypofunctioning parathyroid gland, hypoparathyroidism or pseudo hypoparathyroidism? Keep watching sqadia.com. Thank you very much.